introduce our latest speaker in our CCMBM seminar series. And as many of you know, thank you to all who are here in person and also the many of you on Zoom. We really strive through this seminar series to bring in investigators who represent the gold standard in our field, to inspire us and to help us, really elevate the quality and impact of the science that we're doing. And so it is clear from that rationale why we have invited Dr. Jeffrey Katz to join us today as our seminar speaker. So Dr. Katz comes to us from the Brigham and Women's Hospital and the Harvard Medical School in Boston. He completed his MD and residency at Yale, followed by a fellowship in rheumatology at the Brigham and Women's Hospital, and he's stayed there to pursue his career as a rheumatologist and as a scientist since then. He has made truly distinguished and impactful discoveries that the numerical markers are just kind of eye-popping, with more than 700 peer-reviewed publications, an H-index over 125, and more than 70,000 citations of his research. Now, those are just the academic numbers, but especially those who are orthopedic surgeons or rheumatologists will understand the human impact of this work as well in informing choices about surgical versus non-surgical interventions for joint injuries, meniscus tears, spine and back pain, as well as interventions to help mitigate the severity of OA. Dr. Katz has also played numerous leadership roles, including serving as the president of the Osteoarthritis Research Society International, ORSI, and many other service roles. Another one that's very exciting is his leadership as the PI of the T32. Specifically with respect to his clinical research, he is the director of the Orthopedic and Arthritis Center for Outcomes Research, and is leading a couple of very important multi-center randomized trials called Meteor and Tempo, and I believe those are some of the topics that he'll speak with us about in his research today. In addition to his academic and scientific and clinical accomplishments, I also want to highlight that Dr. Katz is a dedicated mentor. We really aspire to develop scientists on all of these different levels and recognize the importance of mentorship as well. He's received a number of different mentoring awards in recognition of his excellence in this area. So with no further ado, Dr. Katz, it's really a pleasure to have you, and we're looking forward to your presentation.
Good. Thank you. Okay. Yes. Great. Thank you, Tamara, so much. How is my voice? I think it's fine in the room, but outside the room? Some thumbs up? I'll take that as okay. Well, thank you. That's such a lovely intro, and it's really an honor to be here. And I thank Tamara and thank all of you for having me. And I've had a wonderful day so far. And I'm really happy to share the research I'm going to describe, which, as Tamara said, revolves around a couple of trials, mostly Meteor, that relates to meniscal disease. And I have sometimes subtitled this the more we learn, the less we know, but I thought that would probably be a little nihilistic, but that you'll have to tell me in the end whether that's where we end up. So I'm just downshifting. Should I use this? Okay, sorry. Okay, great. So these are my funding sources, none of which I think pose any conflict. So I'll start sort of in maybe a clinical fashion with a frequent presentation to providers who see people with knee pain, a 55-year-old with 3 to 4 years of mild to moderate use-related knee pain, who in the last 8 weeks has had more localized pain medially, worse with pivoting, not getting much benefit from anti-inflammatory medication and is starting to give up valued activities, and so comes for care and on exam is tender in the medial joint line of the knee, has a very small cool effusion. And this is a presentation that occurs probably about 1 million times a year in the US and many millions around the world. And even today, there are about 400,000 arthroscopic partial meniscectomies, which is the procedure that's typically done for this presentation. And so with that as our starting point, I'll maybe talk about the meniscus as a structure first. Is it friend or foe or some of both? So on the one hand, the meniscus is exceptionally valuable. It provides stability. It helps to bear load that would otherwise be borne by the subchondral bone. And in fact, biomechanical cadaver models of load perceived at the subchondral bone under different meniscal conditions suggests that when the meniscus is intact, the load is sort of basal, let's say, and that it goes up a little bit with tears, but even more with partial resection. And so, sorry. If you look on the lower right, you'll see the intact meniscus and the load in megapascals at different stages of the gait cycle. And as we go from a intact to a 30, 60, and 90% radial tear, it's only when you get to very large tears that the load that's perceived by the bone increases substantially. But with partial resection, which is the furthest on the right, it increases quite a bit. And so that's something we'll come back to when we see some of the clinical data, but suggests that the meniscus, even when it is torn, is playing an important structural role. On the other hand, meniscal tear is believed to be a common source of pain and activity limitation, and may be the source of what are sometimes called mechanical symptoms, clicking, popping, giving way. And I'll show you some data on that later that maybe casts some uncertainty about that frequent association between a meniscal flap and these symptoms. Meniscal tear prevalence is very high, and most of these tears are asymptomatic. In fact, 75% of people who do have symptomatic radiographic osteoarthritis, if they were subject to MRI, have meniscal tears. And those with tears have no greater pain than those without tears. And here's a very nice population or community-based study done in Framingham, just outside of Boston, with volunteers who were chosen randomly undergoing knee pain in the Middle Ages. And you can see that the prevalence of meniscal tear rises with age. It's a little bit higher in men than in women. And fully half of men who are in their 60s, let's say, have meniscal tear. The vast majority of people, in this study were asymptomatic. And there was no relationship between symptoms and the presence of these tears. So these are frequent lesions in asymptomatic individuals. So if we return to our 55-year-old, the question is, would surgery, if the person were to elect surgery, relieve pain, improve function? Is it possible, given those biomechanical data, that it would accelerate osteoarthritis progression? The alternative to surgery is generally physical therapy, usually done in a clinic, sometimes just with prescribed exercises at home. And we've more recently begun to ask, is clinic-based physical therapy more effective than simply administering placebo? And does physical therapy add anything to a home exercise program? So those are a series of questions that I hope to lead us through. But let's start in the early 2000s, where the arthroscope, which was really developed following World War II optics innovations, had come into clinical use and was being used quite frequently as arthroscopy became popular to clean out an osteoarthritic knee, with the rationale that there were all sorts of factors that could be lavaged out and there could be debridement. And there was growing skepticism that this was actually a useful procedure. So Bruce Moseley and colleagues at the Houston VA performed the trial that's depicted on this slide, where people with osteoarthritis were randomized to debridement, lavage, and placebo. And you can see there was sort of rapid improvement in all three groups in the first several weeks, and with no difference at all between groups over a 2-year period. Sandy Kirkley, who's a sports surgeon in Canada, who sadly died just before her study was completed, and so it was published posthumously, performed another study that largely replicated the Moseley studies. And so as we got into the latter part of the first decade of this century, it became clear, or it was becoming clear, that arthroscopy is not a good intervention for osteoarthritis, but arthroscopy in people with osteoarthritis is generally done for meniscal tear. And so that gave rise to sort of the next sort of generation of research, which I'll describe. But let me stop and just go back to the question that I raised earlier of whether the meniscus is indeed a source of bothersome symptoms. And so, so here are some data that a couple of colleagues of mine at the Brigham published with me recently, looking at a cohort of individuals who had very detailed assessment of the cartilage, meniscus, and other structures in the knee through MRI and arthroscopically, and then reported on various symptoms. And so here we see that in people who have either no tear, a stable meniscal tear, or an unstable tear, meaning a free flap that might be expected to cause meniscal symptoms, we look at what kinds of symptoms they endorse, and we find that grinding, clicking, and popping in light blue don't seem to be associated with the pathology, but perhaps catching and locking, classic meniscal symptoms, perhaps are associated with meniscal pathology. But in the same group of patients, we also find that those same symptoms, catching and locking, are associated in a dose-dependent fashion with the degree of cartilage damage that was assessed at surgery, the Outerbridge grade, which is an arthroscopic visual assessment. And so when we did more sophisticated modeling to try to disentangle the role of the meniscus and the role of the cartilage grade, it appears that the dominant factor is the role of the cartilage grade. So meniscal symptoms may not be meniscal at all, but may simply be symptoms of the degenerative process and some of the incongruities in surfaces that are produced from that. So that's sobering, but returning to the study of treatments for meniscal tear, during the 10 years or so, starting around 2007 for the following decade, this series of trials was published looking at a similar problem. Each design differed a little bit, but and across several different countries, as you can see. The subjects tended to be middle age, 40s, 50s, 60s. The sample sizes, you can see, vary from 44 to 300 odd. And the interventions were generally, APM here is the surgery, arthroscopic partial meniscectomy. So surgery generally is compared either with exercise or, in 2 instances, with, has a mind of its own, with sham surgery. And I'll say a little bit more about the sham trials in a little bit later. And so I'm going to walk through some of these results, but on this slide, I'll just comment on the rightmost column about the proportion of crossovers. Crossovers were very common in these trials. It's a very interesting methodologic issue when you randomize people in, who are, real life patients to receive physical therapy instead of surgery. They certainly have the option to talk with their surgeons if they're not getting better. And the surgeons in each of these trials, had the option of recommending surgery. And so we can see that about 1/3 of patients do cross over, who were randomized to physical therapy do cross over. So let's look quickly at a couple of these studies. The first one out the gate was Sylvia Herlin, who's a physical therapist in Stockholm, with her colleagues randomized a small group of people to surgery in red or to exercise in blue, and follow them over 60 months with very little damage, but very little difference, sorry, between the two groups, and with 28% crossover. Um, Yim and colleagues is a South Korean study that had a very similar uh, um, design of surgery versus non-operative therapy, which was largely physical therapy. The pain scale is on the left, lower is better, a function scale on the right, higher is better. You can see again, really no difference between the two groups. And interestingly, no crossover in this study. Gaufen and colleagues is a Swedish study. Surgery is in blue. Non-operative therapy, which was physical therapy, is in red. They followed their subjects about 36 months. Here we see an advantage to surgery, which was statistically significant and felt to be clinically important in the intention to treat analysis. Kiese et al. Is another South Denmark, the University of Southern Denmark is a Danish study. Exercise in blue, surgery in red. Again, after 24 months, no difference between the groups with 19% crossover. And Van de Graaff is a Dutch study, particularly nicely done study that shows improvement in both the surgical group in blue and the physical therapy group in white with 29% crossover. And here's Meteor, which is the study that that our group did, and these are our 12-month results with physical therapy in blue, surgery in red, and again by 12 months the groups are identical. You can see in each of these studies, including ours, there's a slight advantage to surgery early on that tends to be neutralized over time, and again 30% crossover. Here's a meta-analysis done by Abram and colleague in the British Journal of Sports Medicine that summarizes several of these trials, and the black triangles represent the meta-analytic results. So, weighting each study by its sample size and by the inversely by its variance, you can see that with respect to on the top, patients with or without osteoarthritis, a slight advantage to surgery on the black dot with the effect is about a third of a standard deviation, which is a small effect. And on those without osteoarthritis, the bottom three studies, a slightly larger effect, both of which were statistically significant. So, and these are the intention to treat analyses. So let's just pause there for a moment, because this is just a really important piece of study design. So here's Meteor, which was our study. We randomized 351 people. And so at the moment that they were randomized, 177 to PT and 174 to surgery or APM, those groups were extremely well balanced. And that's what randomization does. It's a sort of extraordinary technique, really very simple, but because we can't really study the contrafactual, the best we can do is to try to sort of model it experimentally, and randomization is really good at that. But in humans, our narratives change every day, and so when you follow the pathway from sort of north to south on this slide, you can see that over time in the surgical group on the right, 10 of them for various reasons never got their surgery. Fortunately, that was a small number, 164 did. Of the physical therapy group, 68 of the 177, or about 30%, ultimately crossed over to have surgery. And I'll show you just sort of a clinical trace of what was going on, but they basically crossed over because they were doing poorly. And so we end up with these perfectly randomized groups, and the intention to treat analysis, which is what I showed you on each of the previous slides that we looked at, compares those who were randomized to APM with those who were randomized to PT and examines their outcomes, say 12 or 24 months later. But as you can see here in Meteor, in the PT group, a third of the people who contribute to the PT outcome actually got surgery. So there are limitations to some of the inferences that you can make from the intention to treat analysis. One of the things you can do by preserving the ITT, or the intention to treat, and again, it's well worth preserving because there is that balance, which is just sort of extraordinary for inference, that the groups are for all the world identical, not only with respect to variables you can measure, but if you think about this theoretically, even for variables such as their robustness, their optimism, their nihilism, their kvetchiness, all of those things necessarily are randomized as well. So these are perfectly balanced groups. So you sort of disrupt that at your peril. So one of the things you can do is to try to chart the pathway. And so what we did here is to say that that we indicated whether people crossed over, meaning they got a treatment different than the one that they were assigned to. So the non-operatives ultimately got surgery. These 9 APMs didn't get surgery. And then among those who didn't cross over, whether they improved by a clinically important amount. And when we subject the trial to that sort of perspective, we see that 76% of the surgical group improved by a clinically important amount with the treatment they were assigned, and just 54% of the non-operatives improved by a clinically important amount with the treatment they were assigned. And so this, is I think, a reasonably strong argument that there is a role for surgery in this clinical setting. We looked at whether the people who got the delayed surgery, who had PT and then crossed over to surgery, whether their outcomes were similar to those who got immediate surgery, and they were. So in the top line is the group who were randomized to PT and never crossed over, and 73% of them achieved this success criterion that I listed. In those who were randomized to surgery and received surgery, 80% of them achieved the success criterion. And in those who were randomized to PT but crossed over, 81% of those achieved the success criterion. Not all studies have found that. Some have found that crossover surgery is not as effective. And so this is no longer, again, a randomized comparison. So it really needs to be looked at thoughtfully with appropriate adjustments. But anyway, here's some work done by a colleague of mine, Lindsay McFarlane, and the Meteor data, where we suspected clinically, and our clinical colleagues strongly did as well, that those who had the most damage to their knee in terms of osteoarthritic changes would probably improve the least following surgery as compared to non-operative therapy. Sig, hello. Whereas those who had the least damage would improve the most. So what we plotted on the y-axis here is the difference in outcome between the surgical group and the non-operative group. So both groups improved, as you saw from earlier graphs, and we subtract the improvement so that a positive score means more improvement following surgery than following non-operative therapy. And so that we see in people who have relatively little damage to their knee, and we don't see any particular advantage to those who have a lot of damage to their knee. That is very consistent with the sort of clinical teaching, which is that the more damage to the knee, the less likely it is to be helpful to operate on the meniscus. When we followed our group out for 5 years, the crossovers in green, PT, the group who were randomized to PT and didn't cross over in blue, and those who were randomized to surgery in red, we find that after an initial period where the crossovers lagged behind because they weren't doing well, but they eventually had their surgery. So once we get about a year out, these groups look really quite similar. However, when we ask whether they went on to have a knee replacement in the first 5 years, we get a very different story. So the top line shows 109 individuals who had physical therapy without crossover, and 2% of them went on to have a knee replacement in the first 5 years. The next line is the 67 who had PT but then crossed over to surgery. 10% of them had a knee replacement, and those who were randomized to arthroscopic partial meniscectomy, 10% of those had a knee replacement. So a 5-fold greater risk of surgery after 5 years in those who received arthroscopy than in those who did not. This is a pretty interesting result. We're not quite sure how to explain it, but I'll present 2 sort of plausible explanations, which are not mutually exclusive. One is that when you've had one surgery, you're just a little bit more accepting of, enthusiastic about the next. And so it could simply be that, people sort of punched the ticket with one surgery, things went okay. And so when their knee started hurting them again, they were not reluctant, they were fine about having a second surgery. A second, and again, sort of just circling back to some of the cadaver data that we looked at initially, a second possibility is that when you do have surgery, arthroscopic partial meniscectomy, it accelerates the process of osteoarthritis such that people come to knee replacement more quickly. And so we've tried to do a little bit of work to disentangle this. I'll first show you some data from Finland, which was sort of the first publication that looked at this question. And this is a sham study that I'll describe in a little bit more detail in a moment, where the individuals were randomized either to get APM, the arthroscopic partial meniscectomy, or a placebo surgery where the surgeon went into the joint but did not resect the meniscus. And so and they had baseline radiographs, and then here are follow-up standing radiographs 5 years later. And the Orsi score is a score that sums the presence of and severity of osteophytes in 4 different locations and of joint space narrowing medially and laterally. And so we see whether there's a difference, things can only go one way, where there's a worsening in Orsi score in the 2 groups. And you can see that the blue distribution is a little bit more left shifted, the red distribution a little bit more right shifted with a tail. And so, when analyzed formally, these results point to a statistically significantly greater amount of worsening in the surgical group than in the non-operative group. We've just finished some analyses in our own Meteor data, which I haven't published yet. We're just writing them up now, where we looked at sort of a similar thing. We chose a sort of a limited sample of people who had high quality radiographs and met some other inclusion and exclusion criteria, just to try to make it a fair comparison. And we asked the question of whether those who had surgery had greater progression of osteoarthritis than those who had physical therapy. So the Kellgren-Lawrence score is probably familiar to a lot of you. It includes joint space narrowing and osteophytes in a sort of very formal algorithm. And there was very little difference between the APM and the PT groups. The Orsi score, which I showed you a moment ago in the previous, which includes joint space narrowing and osteophytes, shows a much more marked difference. So for example, on the left, under the Orsi score, we see the APM group worsens by 4.2 points, the PT group by 2.6 points. We did a rather sophisticated form of adjustment using a propensity score to try to really, and then so you assign each individual in the cohort, whether they had PT or APM, you create a regression to see what are the factors that are associated with, let's say, having PT as opposed to surgery. And that then becomes a formula for your propensity to have PT. And then if everybody is weighted inversely according to their propensity to have PT, then we end up with a group that is matched on their propensity to have surgery. So that's probably sounds a little complicated, but it's a fairly standard and really nice technique to try to deal with the many things that might, because again, this is no longer a randomized comparison because some of these folks, crossed over. And so anyway, when the Orsi score does make a big difference, when we divide the Orsi score into 2 components, joint space narrowing and osteophytes, the latter, the bottom 2 rows, we see the difference in osteophytes and not in joint space narrowing. So I think the bottom line here is that people who undergo APM are more likely to develop this reactive process in bone over the next 5 years than people who do not. And my colleague, Jamie Collins, who's a very sophisticated statistician, has had a lot of experience working with our Meteor MRI data to look at the question of whether various MRI components, including cartilage scores and osteophyte scores, seem to differ between the surgical group and the PT group. And what you can see here is that there is a difference. It's most marked in the first 18 months, and then both groups seem to follow what is probably simply a natural history of gradual worsening from 18 months to 60 months. But that difference, remains in place. So it does look as though there is worsening occurring with respect to osteophytes from the radiographic data. And here, where we can see cartilage a lot better than you can in X-ray, we see it with cartilage as well. We then ask the question of whether those differences appear to be clinically important. So here we divided our patients, whether they had surgery or not, we divided them into 3 groups represented by blue, red, and orange, which was the extent of worsening on their MRI cartilage score. So the blue had the least amount of worsening, and the green the most amount of worsening in cartilage over 18 months. And then to make the design prospective, we said, now over the subsequent 3.5 years, from months 18 to 60, did those who experienced the most worsening in that initial period on their radiographs tend to have more worsening in pain? And that's represented on the y-axis. And you can see they're indistinguishable. So at least in the first 5-year period, what we think we're observing is that there are changes. Several investigators have now noticed them on radiographs and MRIs that suggest that doing surgery may be causing changes that we would think of as damaging to the knee. But at least within a 5-year time frame, we don't see that those have clinical consequences. And we're following this group now. They're now 13 years, 12, 13, 14 years out, and we're doing a follow-up now to see whether that persists. Excuse me. So this is a really cool result, at which I sort of just ask you to look at these slides for a moment. So Shivonen and colleague, this is a Finnish group that performed, I think, a really extraordinary study. Most of my surgical colleagues have found many reasons to criticize this study because it is just such a disturbing study in many ways. But this is why we gather data, right? So they randomized about 146 people who had very little osteoarthritis at baseline and who were middle-aged, to either have arthroscopic partial meniscectomy in blue or a sham surgery that I described a moment ago in red, where they were brought to the operating room. The arthroscope was entered into the joint, but no intervention was made with respect to the meniscus. The arthroscope was simply withdrawn. And then the patients were blinded, the assessors were blinded, and you can see that at 12 months, and they've replicated these data out to 3 years, the patient status was identical. They improve actually considerably on both of these measures. And you can see on the right, the surgical group improves a little bit more initially, which we saw in some of the other trials. By 12 months, they're identical. So let's just maybe back up a little bit and talk about some of the sort of conceptual issues about placebo. They're interesting. So if we think about a trial, for example, of a pill that would lower your blood pressure versus a placebo pill, we can envision that on the right here is the individual who's not in the trial at all, who might have some fluctuation, and so there might be some effect, some regression to the mean, for example, that simply represents sort of a natural fluctuation that is probably not meaningful. We have then the next individual who took the placebo, and in virtually all trials, including in blood pressure trials, even if you're measuring something as objective as blood pressure, and certainly if you're measuring pain, the placebo effect tends to be substantial. And so as compared to the person who had no treatment at all, the person who had placebo has had this intervention. They had a pill, they had expectations that the pill might help them because they're blinded, right? And so they show some benefit, but what they took has no physiologic benefit that we're aware of. And then the person who took the blood pressure pill might be the person on the left who had the active treatment. And what we would be measuring on the y-axis here would be something related to blood pressure. And if it was a pain pill, it might be a pain level or a function level. And so the way that we conceptualize this is to say that, that the direct effect of the active treatment is the difference between the active treatment and the placebo treatment bars, right? And which in this case would be about, 13 to 20 would be maybe 7 points, and the placebo effect would be another maybe 7 points, and just the sort of control where you start might be 5 points. And so from that point of view, if we think about the Finnish trial, what we see here is that the group goes from a Lesham score of 60 up to about 80, which is actually a marked improvement. So the total effect is actually very large, but the direct effect is 0. Because the placebo effect is equal to the total effect. Now, if you ask the patients in those studies whether they were glad they participated in this study, they would all say that they were, I would assume, because they got markedly better. So what the subject or what the patient experiences is neither the placebo effect nor the direct effect. They wouldn't describe it that way. They either got better or they didn't. So that's the total effect, which here is 20 points. And confusion and speculation around this issue has caused some really interesting and actually quite important discussions. So many of our colleagues in Scandinavia, in response to the Lesham study, have called quite vociferously for meniscal surgery to be discontinued in Sweden and in Finland, and with some insurers have been quite successful. And it's always struck me that it was not a particularly sophisticated way of thinking about what a placebo effect is. I would make the conclusion from this that, if we, had to choose between no treatment or placebo treatment or APM, I would be indifferent between placebo and APM. And given what we think might be some adverse effects of resecting the meniscus, I'd probably prefer to have placebo arthroscopy rather than no treatment at all. I mean, that's a little bit perhaps said in jest, but not exactly, right? Because placebo effects are very real. And so where there is no placebo, so we don't administer placebo partial meniscectomy. And so I think it's a thought-provoking discussion. I don't think it's a no-brainer, but it strikes me as being rather not particularly thoughtful to say that on the basis of what they found, marked improvements in both groups, that you would discontinue the active surgery. Just a few concluding remarks. So we have seen then that the sham effect, the placebo effect of surgery, is very large. We haven't really looked yet at the placebo effect of physical therapy. What is the active ingredient of physical therapy? And so we began to think about this a lot after seeing the Finnish study and a number of other placebo studies that are increasingly we're seeing in musculoskeletal problems. And so, is the active ingredient of physical therapy the physiologic changes, the strengthening of muscles? Is it the interaction, the interpersonal interaction with the therapist? And could those be replicated? Could those interpersonal reactions be the whole effect, so that if we had sham PT, would sham PT be just as good as regular PT? So one sort of observation we made along the way, and we did this in Meteor data, was to say, I wonder how much of the improvement that we observed in Meteor patients who had physical therapy was mediated by improvement of strength, which was one of the key objectives of physical therapy. And maybe in the interest of time, I won't walk through the slide in detail, other than to maybe conclude that the correlation between changes in strength and changes in pain were minimal, on the order of 0.1 to 0.17. And so what we find is that patients go to the physical therapist, they have a lot of focus on strengthening, they experience some improvement in their symptoms, but the extent of strengthening has no bearing on the extent of improvement in symptoms. So that made us wonder as well. And so we've initiated Tempo, which we hoped to have completed a while ago, but COVID got in the way, but we have completed enrollment. So this is a NIH-funded randomized controlled trial at the 4 sites that are listed. And the premise was that the therapeutic impact of physical therapy arises from both physiologic and contextual effects. And so we're trying to really sort those out here. So Arm 1 just gets a home exercise program with a DVD and a pamphlet. It's a really nicely done program. Arm 2 gets that, but we also text them twice a week to try to improve their adherence to the home exercises. Arm 3 gets all of that, but they also come in to see a therapist and they get sham PT, which is ultrasound with the machine not turned on, so that it's making all kinds of lights and it makes a little noise, but there's no energy, and we have sort of a sham massage that they get. And then Arm 4 gets straight up physical therapy. And so we're interested in knowing between 3 and 4 whether there is really any difference if you do come in to see the therapist and have that sort of hands-on treatment about the actual, physiologic, are there actually physiologic benefits from strengthening that translate into improvements in pain. And we're interested in terms of the difference between those arms and the other arms, whether there's a benefit to actually coming in, or could you benefit just as much by simply being treated at home? That would have major cost implications. So we finished randomization of 779 patients, and we'll finish our 1-year follow-up in about 8 months. And so we'll be doing the analyses of that trial a year from now. So just to summarize, meniscal tear is common. It's associated with OA. It may or may not be associated with meniscal symptoms. I think we genuinely don't know that physical therapy, surgery, and sham surgery all appear to be associated with rapid sustained pain relief. The intention to treat findings suggest that the PT arm and the surgery arm eventuate in similar outcomes at 1 year, with a meta-analysis of those ITT findings showing a small benefit of surgery that doesn't appear to be clinically meaningful. But if you think about it more thinking about the pathway and sort of more formally doing as treated analyses, because of this large crossover rate, the as treated analyses do favor surgery. So there is a role for surgery, which is, again, one of the things that to me is problematic about what our colleagues in Scandinavia are advocating. The fact that APM may be no more effective than a sham surgical procedure, I think, is a really thought-provoking observation, came from an extremely well-done trial. We do know that the total effects are large and that the direct effect of APM may be small. And so we're interested now in what is the direct effect of physical therapy. And with respect to 5 years, what we've really learned is that there appears to be some effect of surgery on progression of osteoarthritis. So we think it's reasonable to offer PT as a first-line therapy. It seems perfectly reasonable to offer surgery to those who don't respond to PT. From a research standpoint, we're really interested in the effect of the placebo mechanism in people who undergo PT. We wonder, if you fail, so to speak, PT, whether surgery should be the next step, or whether there should be, again, given that there may be some real downsides to surgery. So we've just gotten a planning grant to try to look at to sort of mount a trial of surgery versus an enhanced non-operative regimen for people who don't benefit from PT. And then we are really fascinated by this observation that there is faster structural progression in those who have surgery, which, if we believe in the whole canon of osteoarthritis, that structure should eventually result in symptoms, but we haven't seen it yet. And so we have some funding now to look at that And the policy again is I just have a real problem with, trying to deny coverage for these things. So I've worked with a wonderful bunch of people, some of whom I put on the screen here, and there are too many to list. But these are our centers for the Meteor study, for the Tempo study, and then some really wonderful colleagues of mine back at the Brigham who I've mentioned here. And I'd be very happy to take any questions that you might have.
Thank you, Dr. Katz. For those on Zoom, feel free to unmute to ask your questions or put them in the chat and we'll read them.
Yes.
I really enjoyed your talk. I have a question about specificity of your talk. Nature of my question relates to your talk.
Yeah, it's a great, important question. And actually, there are some data now. There have been now 2 trials mounted, one in Denmark and one in Sweden, that are sort of the same sort of design as Meteor, targeted those younger people, again, feeling that, the the benefits and the potential disadvantages really ought to be examined. So the part that we know is that it appears that younger people treated non-operatively have similar outcomes 1 year later as younger people treated operatively. Very similar to Meteor. That was a great surprise, I think, to many people in the field, including me, who just thought that the problem here was that the degenerative meniscal tear is sort of a form fruste, perhaps, of osteoarthritis, and that what was happening in the younger 29-year-old ultimate frisbee player was a real mechanical lesion that ought to be fixed. But these studies have really suggested that we pause about jumping to that conclusion. I think the other half of your question, which has not, I don't think these investigators have published on yet, but I'm sure they will, is whether we've seen the same effects of meniscal surgery on the cartilage. And if so, there's a lot more at stake, right? Because the 29-year-old frisbee player has a lot of steps in front of her or him, and so there's more to be lost if surgery has deleterious effects on the knee joint. So I think more on that coming. Yes. Sam, do you want to shout it out?
Absolutely. Jeff, thanks again for a very thought-provoking talk. As I mentioned to you this morning when we chatted, I have a personal interest in this, having undergone 2 knee surgeries, and I'm very much solidly in middle age right now. So this has me thinking a lot. My question for you is whether activity level could account for some of the greater structural degradations that we see at MRI in 5 years in your APM patients. So is there a possibility that somebody, like me, gets surgery and thinks they can be much more active than they ought to be, and goes out and starts playing singles tennis and soccer and all these things that got them into this mess? Again, and that, so I imagine that this has been looked at in some of these studies.
It's a very astute question, and I don't actually think we have a really good answer to that. We've wondered about that as well. If we look at sort of self-report function scores and some self-report activity scores, that doesn't appear to explain the difference. But those are, I think there's a lot of work suggesting that self-reported physical activity is really rather imprecise, and so I think that is possible that it's a sort of that, you make people well enough that they can really damage their knees further. I think that is possible. I suspect that, the stark differences, for example, in total knee replacement rates probably aren't explained fully by that, but I think that that's a really important, hypothesis. And I'm sorry I didn't mention it when I went through that discussion. Yeah, thank you.
Thank you.
Sig. Yes.
Thank you for truly insightful presentation, and actually you really made complex problems clear. Fantastic. I'm interested in how it might apply some principles of learning or principles of cluster analysis. Really look at this. If we get the mentioned diagram, overlap of the APM and the CAM was really quite remarkable. And really the standardization is actually quite small.
Yeah.
But if you actually look at the data of individuals, what we see is we see a lot of fields with something that got better, something that got worse. And as you know, and Steve will talk about that, the trouble with interpreting the mean is that it doesn't really tell what happened to the individual. I wanted to get much more precise. There's so many variables that we can't really capture right now. The genomic information, the radiomes, right? The care pattern, the location of care, the alignment of the knee. So with your fabrication analysis and propensity scoring, we took a lot of the known variables, maybe BMI, maybe gender, and other things into account. But there's so many subtle things because what I'm trying to do was the underlying alignment of the radio. Create a predictive model to actually be able to see which patient is likely to improve, if not improve a lot. Which patient is likely to stay the same, or which ones are likely to get worse.
Yeah, and so it's a great question, Sig. Gosh, how long has it been? We traveled the same corridors many years ago before Sig came out here and has had such a wonderful career here. So I think there are maybe two questions. One is there a better way of understanding the difference between the two therapeutic approaches that might make use of more advanced analytics? I think the answer is no. And I think, again, this is the sort of beauty of randomization, is that there are no confounders in randomized controlled trials. To be a confounder, a variable has to be associated with the exposure and the outcome. And when the exposure is determined by randomization, whether you are in group A or group B, then the variables that we might think of, such as your Kellgren-Lawrence grade or your sex or your age or your activity level, are balanced evenly. And we can prove that by looking, at the kind of table 1. But then all the other variables, whether they be genetic or behavioral or attitudinal, are at least theoretically, and when you get to samples, in getting toward 200, they are always balanced as well. And so I think that advanced analytics don't really do the work in terms of sorting out therapeutic differences between strategies. At the individual level, what is likely to, whether the person received, surgery or placebo or PT, what are some of the factors that might have some of them, an individual improve and another one not improve? That is now a predictive model. And so you would, and so I think some of the things that you mentioned, could be very useful. And that is sometimes useful for just helping patients to understand what their own personal likely trajectory is. I don't think, I think there are many circumstances where machine learning really helps us, where the data are very complex and the data sets are large. I think here, because it helps us to identify effects that are really very small. In some ways, we're not that interested in small effects. We're interested in larger effects. So I don't think this is a place where I see machine learning being, really sort of moving the field forward a great deal. I think when you have large databases where you there may be some, and where there is a lot of like, for example, medical record-based data, which should never be used to compare treatment A to treatment B because it's hopelessly confounded. You can learn a lot about individual trajectories. And there, I think machine learning can be really helpful to deal with some of the temporal issues that arise when people show up because they're in pain. And that, there's a lot of things that standard, epidemiologic and statistical techniques sort of struggle with. And to some extent, if done thoughtfully, and in I think a supervised, not an unsupervised manner, because if we're not laying out hypotheses, then we're discovering all sorts of things that we can't really necessarily make sense of. So I think their advanced techniques can be very helpful. But I think what the Finnish group did is really extraordinary. I think it's an amazing trial, and I've not personally questioned their results, just tried to understand them.
Certainly makes sense with at a population basis, the clinical practice guideline.
Yeah.
That probably does drive policy.
Yes.
At the same time, I think we're myopic about subset of patients, and trying to really identify what's right for the individual.
Yeah.
Population dynamics for the individual. That's where
Yes, exactly. And I think it's what should make one really reluctant to toss out therapies, even if, given fairly rigorous analyses, they don't demonstrate group differences in outcome, because we now, through various analytic techniques, can perhaps identify responders a little bit more accurately than perhaps we, could or chose to a number of years ago. Yeah, that's a very interesting question. I've thought about that a little bit, and the question is osteophyte the villain, or is it just a marker of the process that is occurring? And so I think you understand this better than I, Tamara, but I'll give sort of a shot at it. That I think that bone is just behaving as bone behaves, right? And so when the pressures that are born on bone increase, the bone will react. And so we see osteophytes. We also see changes in shape. There's a whole bunch of bony manifestations. And there's really quite a bit of debate in the field as to whether those should be somehow suppressed in order to make people more comfortable, or whether they are simply sort of giving us the objective evidence of processes that are a little harder to see, which is that there are these abnormal forces that are putting pressure on the bone, and the bone hurts, because where do we have nerve endings, right? So it's bone and it's synovium. So I don't know. I mean, there are, these kind of more atrophic forms of osteoarthritis. They hurt just as much. So I think, in the spine, right? Like if SIG could stop osteophytes, then there'd be a lot less spinal stenosis. Whether that's a good thing or a bad thing depends on what you do for a living. But from the standpoint of all the patients with spinal stenosis, suppressing osteophytes would be very helpful. I just don't know in this setting. My sense is that they are just, waving the flag saying this knee is damaged. And so that's my hypothesis, but it's a little out of my area. But what do you think? Yeah. Thank you all very much.